of us. I've met some of you before. Some of you have our t-shirt on already. If you don't have a t-shirt, they're complimentary, so get one on the way out. We have some literature at the desk. If you haven't signed up, please sign up. If you have signed up before, be sure you put a card in with your name, because that's what the drawing is going to come from. That way we won't give you, multiple, you won't get multiple mailings from us, because we'll just have your name and your address. So I saw in the debate last week that Governor Romney mentioned Obamacare, and President Obama says, yes, I embrace that now, I love that name. And I'm suggesting that he better hug it real tight, because after November 6th, he's not going to see it again. Couldn't be more pleased to have Dr. Novack, who had a great chance to visit. He is an orthopedic surgeon, flew in from Phoenix to talk to you just today. And we're going to do it a little bit differently than our first meeting. We're going to have him talk for a little bit, and then we're going to have some Q&A, because I know some of you probably have some questions about ObamaCare, about Medicare, et cetera, et cetera. So Mr. Novack, or Dr. Novack, has spoken on healthcare issues across the United States. He's had a radio program, and it's definitely like a second career for him. So please welcome Dr. Novack.
Thank you. Can everybody hear me? It's much more relaxing for me as opposed to standing behind the podium with a microphone. So just shout at me if I am not being loud. And thanks for you all being here. I did come in from Phoenix on the red eye, and it's nice to see that there's Phoenix weather. So I appreciate you bringing that over. It's probably only, at this point, 4 or 5 degrees warmer in Phoenix today than it is here. So, not quite what I expected. But I have been extremely fortunate over the last several years to be able to talk all over the country, testify in Congress, to people about healthcare policy, not just from the trenches of someone who's providing care, but also just strictly to the policy side. Now, my day job obviously is doing orthopedics, but I tend to do this on the side, so I do a lot of 24-hour round-trip visits, including today. So I took the red eye in last night, and I'll leave early this evening from Midway to go back to Phoenix. But in August, beginning of August, I was invited to participate in an event at the Bipartisan Policy Center in Washington, which was an event that was also put up by the Hill newspaper, and they were looking at 5 issues that would decide the election, one of which, of course, is health care. And so I flew in to Baltimore, because that was the only place I could get on such short notice. They drive you then to D.C., you change into your suit in the bathroom, in the men's room, and then you do this talk, and then I had lunch, and then I was back at the airport now to fly back. So I was beyond exhausted. Get on the plane, and I've been flying so much, I got this automatic upgrade, so I get in front of the plane, pass over my suit coat, and immediately start to drool for the next 5 hours. Well, it was the beginning of August, and the Senate had just gone out for recess, so both Senator John McCain, and Senator John Kyle, both our 2 Arizona U.S. senators, were on the flight. And fortunately, since we are all paying for their seats, they were not in first class. So they're on the plane, and I don't think I even woke up until the wheels already touched the ground. They hand me back my suit coat, and I cannot wait to get off the plane because I just want to get home. And I get to the moving walkway, down the thing from the terminal, from the gate, and I hear overhead that if you were on the flight from Washington, and you might have taken the wrong suit coat, please return to the gate. So it was just something that I knew that I looked down, and of course, matched perfectly, but I looked down and there was way too much white shirt showing. So now I knew I was in very, very big trouble. And I kind of looked at the inside, and there of course was John McCain's name on the inside of my suit coat, or his suit coat. So now I'm going to go back to the gate. But my hands are full because people said to me, why didn't you take his coat off once you realized it wasn't yours? Well, I didn't want to bring it back, dragging it on the ground behind me. So I get back to the gate, and of course, they have the Phoenix police meet the senators at the airport just for security reasons. Senator Kyle gets the Secret Service because he's number 3 in the Senate leadership. McCain just gets the police. So of course, I get back to the gate. There are 2 or 3 police officers there. And Senator McCain has been rummaging through my pockets. He's been trying to find anything that would be the identifying feature, but he was very gracious about the entire thing. So I promise you, these are my own clothes that I'm actually wearing. That's my travel story to start with. There is nothing more important than healthcare. I know that's why you all are here. I was involved in one of Frank Luntz's focus groups that he held in Phoenix about just under 2 weeks ago. And it was a neat opportunity. We all sit behind the one-way glass, by the way, while it's going on, so we can see what's going on. But I was able to go out there and ask some questions about healthcare to the group. And it was the so-called undecided voters. And so I asked simply, which is, for how many of you is healthcare an unbelievably important issue? And of course, even after all this time, every single person raises their hand. Now, we haven't seen a lot devoted to healthcare, I think, during the presidential season for a variety of reasons, but nothing is more important. And so, what I would like to do over the next few minutes, and some of this may be news to you, some of it may not be news to you, is just run over a few things in the healthcare law that I think might be pertinent or valuable, and then set up the stage for a conversation for any questions or comments you may have. Then we'll go from there. Again, I do have to head back all the way to Midway for a 7 o'clock-ish flight, so I can't stay too long after. The one this morning went on, it's supposed to be an hour, and I think right around 2 hours we finally had to go. So, and thank you very much to 60 plus. All of you obviously are here because of 60 plus. They really are the alternative to AARP. As you'll hear, AARP has a significant financial stake in just about everything related to the healthcare law. And 60 Plus Association is not trying to sell you anything. They really are there working on the issues to ensure that the programs that you've paid into all of your working lives, for some of you, will continue to be there for you, and also create an environment where they will be able to be there for your families as well. And I used to do it as a volunteer for them, so again, I feel fortunate to be able to do it for Jim Martin, who's the chairman and founder of 60 Plus, and the rest of his group, and they have about 7 million members nationwide. So I know that by signing in here today, they'll make sure they get you on the list because they do some great work. It is important to me that we not forget what healthcare is all about. It's not ultimately about politicians pontificating in front of the camera. It's not about supposedly smart people spouting off statistics. It's ultimately about what happens when you go to the doctor, or you go to the doctor with your spouse, or when you have a child who needs to go to the doctor, or a child that is taking their parent to the doctor. And that individual interaction is what is critically important. 2 very brief stories of why I'm here and what really motivated me to get involved with this. Since I've been in practice doing orthopedics for the last dozen years or so, but I've been involved in delivering healthcare for about 24 years. I started as an EMT in Bridgeport, Connecticut, doing 911 during the sort of rough and tumble days of the 1980 crack era in an inner city neighborhood. Now it's been about 4 or 5 years, but right around Thanksgiving time, I had about a 90-year-old woman who had fallen and broken her hip, which they tend to do. On paper, she looked bad. In person, she looked worse. I think that a lot of the 90-year-olds I get to see in the office, they work hard to be looking as good as they can when they come in to see me. And when they're hurting and in pain in the hospital, they've not had the opportunity to print. In fact, if you looked at her, you may have thought she may have already moved on to another place a couple of days before I got to see her. And on paper, again, she didn't look so great either. So we had a conversation with her and her family. Her family was clear. They said, we know she doesn't look so good, but she really gets along pretty well. And I said, well, she has a lot of risks. There's obviously a risk that she might not survive the surgery or shortly after. And just because we can do an operation every time doesn't always mean that we should. But I don't know. I'm meeting the patient for the first time. Oftentimes, sometimes it's even in the pre-op area before surgery. So these are, you can only bring in so much, you only have so much information. And they said, well, no, really, she does okay. And so we had the conversation, and they wanted to proceed, so we did. And as I like to tell folks, over the last dozen years, I've been probably done about 5,000 or so surgeries and seen about 50,000 or so people in the office, plus families. So at some point, to be honest, you sort of lose track of individual ones, but other things that have stood out was getting a phone call 6 months later from the granddaughter saying that grandma just came walking into Easter dinner. Well, slowly, but she came walking into Easter dinner, and how thankful they were that we were able to get her taken care of, and all this, and the great opportunities that she and her family have had since that time. So when we think about healthcare, that's what this is really all about, which is trying to keep healthcare decisions in the hands of patients and families, hopefully in some consultation with providers as well. But we want to keep that decision-making power, to the extent possible, out of the hands of politicians, out of the hands of government bureaucrats, and out of the hands of people sitting inside insurance companies who really have no interest in individuals. It's always part of a greater statistic. And that's ultimately how I got involved with the policy side, was an increasing recognition, was that the forces against us were getting stronger and stronger and stronger, and more bold. And frankly, I would say more and more careless, because their ultimate motives were becoming more and more clear. Which is, as I like to put it, they talk about commoditizing the service, right? To say that when you go to the doctor, and you go to the doctor, if you have a similar condition, you get a similar kind of treatment. And we do need some better standardization, so there's some more consistency. But what they're really doing is commoditizing not the service, but they're more and more commoditizing the patient. So that everybody here ultimately is either a cost center or a profit center for whether it's an insurance company or a hospital. And that's where I'm afraid that we're moving. That's where I am certain the incentives that are created under the President's healthcare law are pushing us. And that's what I do believe, honestly, that if we work together over time, we can begin to turn the ship around. So with that as the background, a couple of things to cover in the law, and then we'll open it up to fun, so we can talk about what you guys think is most important, not me. The $716 billion in cuts to Medicare, which if you have a TV, you probably have seen it a few million times. On both sides, trying to make claims about the other side. The short version is, those $700 billion plus in cuts to Medicare in the healthcare law are real. They're real. They take that money and they use it to effectively fund direct government subsidies to the health insurance industry for our brand new entitlement program. Except for the fact that the $716 billion doesn't even come close to covering the $1 trillion plus that's going to be handed over to a handful of insurance companies and hospitals over the next 10 years. Now, what are they specifically going to be taking away the money from? The single biggest category to talk about is Medicare Advantage. That is the people who are on the Medicare managed care plans. Is there anybody here who's on a Pacific Care Senior or Cigna Senior? Is anybody on a Medicare Advantage plan here in the room? So you are still in the majority, but 11 million seniors nationwide are on Medicare Advantage plans. And while it's all flawed, if you're on a Medicare Advantage plan, it's one-stop shopping. You don't need a Medigap policy. You don't need a Medicare prescription drug policy. There are always going to be benefits that are not covered under standard Medicare that are involved in Medicare Advantage plans. There are trade-offs along the way, but those are some of the potential benefits. So one of the things that you might find is that we know standard Medicare doesn't cover hearing aids, but a lot of the Medicare Advantage plans may actually have hearing benefits built in. So those are some of the reasons. About $200 billion, depending on how you calculate it, is cut from Medicare Advantage over the next decade. In fact, the president and the Democrats demagogued the insurance companies endlessly about this during the debate in 2009 and 2010. So by the administration's own people, they estimate that half of all the people on a Medicare Advantage plan today will not be able to have it by the end of the decade, because those programs just simply won't exist. Well, who uses Medicare Advantage disproportionately? It is available for all seniors who are eligible for Medicare. It does vary a bit in terms of the choices and value of it, depending upon where you are geographically. But if you look nationwide, the group that uses it are low income and even particularly non-white low income seniors. A few years ago, they looked at who uses it. 80% of Hispanic seniors making less than $20,000 per year run a Medicare Advantage plan. Those people are going to, more likely than not, lose what they have. And one of the president's most common refrains, I'm sure, if you were paying even a shred of attention, was, if you like your doctor or your plan, you'll be able to keep it. That is absolutely, positively not the case. Now, even the president's people realize what's going to happen, which is why they raided $8 billion from a, quote, demonstration product pool, because everyone should have $8 billion laying around and pass out, to basically prop up the Medicare Advantage plan through this year so they can get through the election cycle. Now, even the General Accounting Office, which should be one of the watchdogs for government spending, said that they have never heard of a demonstration project costing $8 billion. It's totally wasteful, and the program should be stopped. So, of course, the Obama administration continued. So that's why you're not seeing the big changes in Medicare Advantage going into the open enrollment season, which is probably just about starting, if it hasn't already. On the Medicare Advantage front, you may even see that your premiums will be about the same year over year. And that's because effectively they've dumped $8 billion into the plans to prop them up through this cycle. That matters. And when it comes to access to care, we all believe that there are certainly people who have medical conditions who need greater access to care who aren't currently getting it. Right? There's no question. Most of us probably even know somebody who fits in that category. So when the president said we need to get better access to care for those folks in 2009, and I agreed with him. When the president said that health care is too expensive, I agreed with him. I would joke that there could be surveys that showed that 89% of people said that health care was too expensive. This is from 2009. And I would get up in front of groups and I'd say, I have yet to meet any one of the 11% of people who don't think that health care is too expensive. One of the gentlemen here was just showing me a prescription he had just gotten the other day for reflux medication, which is also available over the counter, but he wanted the higher doses, so we got a prescription for the higher dose. Well, if you were paying cash, it was $6 a pill. With the prescription, it was something like 60 cents or less. So we do have significant issues with cost. The problem, of course, is that the healthcare law is going in the opposite direction. Other cuts that are put in under the law are going to take money further and further away from hospitals that particularly cater to low-income, inner-city, and rural areas. Those will all mean that access to the care for people who live in those areas is going to go further down. They'll have to go further for care and have fewer options. You will also probably notice that I'm sure it's happening here because it's happening everywhere, is you're seeing a significant consolidation in the hospital market, and that different hospital systems seem to be buying each other. And of course, the number of total insurance companies has already begun to drop as they start buying up each other. The smaller ones are going away. Fewer choices are ultimately going to be higher prices, because it does work that way in every other part of our economy. And when it comes to the consolidation of hospitals, what we're seeing around the country, I don't believe it has begun to start here in this area yet, but I guarantee you it's coming, is the hospitals are, what they call is a hub and spoke philosophy. Right now, most of the community hospitals will cover most of the services and most of the care that you need. There tends to be some either specialized treatment that not many people offer, or specialized services that aren't available everywhere. But for the most part, your community hospital offers a wide array of treatment choices comparable to what you might get downtown. What hospital systems are beginning to do is say, well, it's just not profitable. So what they're saying is, well, we can provide that dialysis treatment, we can provide that cancer care, we can provide that treatment much more efficiently and better quality if we move it all to the center hub in the beginning, in the middle. And we're going to start pulling all those services, or reducing the number of services that are available in the outlying hospitals. It's all about, of course, saving money, and has less to do with quality. But those are the kinds of things that the incentives that the law is putting in place are actually doing. It is hugely destructive to where we started, which is we want to try to keep patients and families in control of health and healthcare decisions. I can go on about the Medicare stuff. There may be other questions, but I want to just cover one other sort of major topic at the start here, which is Independent Payment Advisory Board. Is everyone familiar with the IPAB? Is that a new term to people? Anybody who's not heard of that term before? All right. So they want to reduce spending on healthcare in Medicare. So the president and his allies put into the law an Independent Payment Advisory Board. That's what it's called. It's going to be 15 people appointed by the president, and their job is that if healthcare spending in Medicare is going up more than 1% faster than gross domestic product, which, to not make it too boring, means that, well, for the last 30 years, healthcare spending has gone up at a higher rate than that. So the likelihood it's going to suddenly drop down below that seems unlikely. Those 15 people will have the ability to determine how much different services are getting paid for under Medicare. Now, the Democrats go on and on saying they have no ability to change what services are available. They cannot change the benefit package. But what they will do is reduce how much people get paid to where they don't want to offer. And they will let them go where the money is. Because if they're trying to save money, they're not going to go to the little thing over here. They're going to go to something bigger. And so what they will end up doing is, if, for example, currently there's a payment of $10 for a service, but it costs $9 to deliver the service, they may decide arbitrarily that to save money, we're only going to pay $8 for the same service now. Well, what exactly do you think is going to happen in pretty short order once they stop paying people enough to even break even for the service? You're going to find that you get progressively less. So that's okay. So the bureaucrats, of course, will say, we didn't cut the benefits. It's those mean-horrible providers that aren't offering the service anymore. But they are ultimately creating the environment by which there's less care available for all of us. So that's the Independent Payment Advisory Board. And by the way, again, people know it's not popular. There's actually bipartisan opposition to getting rid of it. And under the law, the president was supposed to have appointed the 15 people. Guess how many people he's even put up to the U.S. Senate for confirmation? 0. There is almost not a piece of this law that is remotely popular, in spite of what you hear. Once you get down to the weeds of understanding what it means, they changed it to say that you couldn't sell child policies that prevent people from buying them for pre-existing conditions, or put limitations on it. Well, as a result, about 3/4 of the states you can no longer buy a child-only healthcare policy. They no longer exist. For most working people with children, who are healthy, which is the 90+% of children, it is almost always, it had been almost always cheaper to, if you wanted to get your own health insurance through your work. And then instead of buying the family policy, which would cost a lot more, go out and buy a child-only policy on your own. Because again, if for most healthy children, going to the doctor once or twice a year, the insurance was very inexpensive. Now, those same workers are being forced, if they want coverage for their children, to get it through their employer, which, as you read in every single news report, more and more and more of those costs are being passed directly on to employees. Much more expensive than it used to be. Final point. Allowing children to stay on their parents' insurance until they're age 26. Sound like a good idea? For those of you who may be old enough to not to have children who are older than 26, probably most of you, when you had children who are younger than 26, for the most part, you probably would have been very happy for your children not to stay on your insurance and go out and do things on their own. Again, we do have an issue, but the policies made it harder not only for the child policies to be purchased, but there are fewer individual adult policies as well. There are estimates, of course, do vary, but it is believed that that child age 26 policy, part of the law, can raise the cost of health insurance for a family policy by up to 3%. So if the average family health care policy now is closing in on $15,000 per year, that's up to an additional $450 a year tax on working families, particularly younger working families who couldn't possibly have a child old enough to benefit from it. So while they're claiming they're doing one thing, the actual incentives they're putting in place are resulting in higher costs and less access to care. And when it comes to Medicare, they are stealing huge amounts of dollars from a program that's already struggling and using it to fund a brand new entitlement that they cannot possibly afford. The country, there is no permutation under which this country could afford to pay the actual cost of the subsidies that are going directly to health insurance companies that will actually make the numbers work for most working American families. And if you go to the meetings and you try to talk to the people who are trying to implement these policies and you give them data and say, please explain to me how this is going to work, they cannot answer the question. They do not even try. Because for the handful of insurance companies and the handful of mega hospitals, it is all about getting this access to this $1 trillion in extra money. That doesn't count, by the way, the $900 billion in Medicare money, Medicaid money that they're trying to get as well. So before I stop, I'll say it's easy to hear this and say, do we just go outside and sort of throw ourselves in front of the city bus? Is this? And my answer is no, because I wouldn't be here if I thought it was totally bleak. Just the fact that there are so many people out here on a Wednesday afternoon to talk about healthcare is a sign that we can turn things around. If Governor Romney wins in 13 days, and I hope he does, we need eternal vigilance. His program in Massachusetts, while he likes to tout that it did get more people insured, it did. It is bankrupting the state of Massachusetts. Healthcare spending in Massachusetts is now closing in somewhere on the range of 50% of the entire state budget. And if it weren't for literally hundreds and hundreds of millions of dollars of federal dollars to prop it up, the state of Massachusetts would be bankrupt already. Senator John Kerry stuck literally one sentence into the healthcare law that reclassified every hospital in Massachusetts to get a higher rate of payment from Medicare. That translates to about $120 million a year extra for Massachusetts hospitals. And that money did come out of the total Medicare pool. So it came out of Illinois, it came out of Arizona, it came out of the other states. So it has not been a big issue. And Governor Romney does have a lot of people around him who are not what you would say necessarily limited government advocates for health care. So regardless of who wins in 2 weeks, we need to make sure we're holding people's feet to the fire. Can we make it work? Yes. In Arizona, the head of the banking and well, soon to be former head of the Banking and Insurance Committee in the House, Republican. I was working on a bill on some transparency issues for consumers, and I was in her office with a former U.S. congressman. So, who cares about me, but you'd expect a modicum of respect for a former 6-term U.S. congressman. She said to the two of us, I don't care what you think. I only care what Blue Cross Blue Shield of Arizona thinks. That's what she told us. We were able to run a very good and strong independent expenditure effort against her, and she lost the primary to actually a physician, woman who is going to be elected to the state senate going forward. So we will have a better advocate. Nothing, I will say that for better or for worse, that I've been doing on the Arizona political side has had a greater impact in sharpening the focus for legislators than that one primary race. And that's the kind of activist work that ultimately is grassroots work. The people who will not stand up for patients and families, the people who are willing to, as I like to term it, are willing to basically turn your health care over to the suits, whether it's the insurance company suits, the hospital suits, the bureaucrats, or the politicians. We can fight back against them. And I do believe we can do it successfully. We've got to get this ship turned around. And I do think 60 Plus is one of the best organizations that we have out there as partners to help us stay informed. So with that, if people have questions about the healthcare law, about Governor Romney's ideas for what he's proposing, or anything else, let me open up to questions for a bit as well. Yes, ma'am.
Okay. When this first started, I got a brochure in the mail that it talked about the panel.
Yes.
And that caught my eye immediately. So of course I called the number that was on it, HHS. They had no idea what I was talking about. They gave me another number. That number didn't know. I talked about 3 or 4 different numbers. They didn't know what I was talking about, so I emailed Fox News. Well, my understanding that this panel is a group of people that's going to make a decision about my care. The question is, are those panels in each hospital? Because I don't want nobody deciding what I need.
Sure.
And that frightens me.
If it comes simply to the issue of are there panels created under the law, I believe one of the organizations that come up with a list, there's about 150 new panels or boards that are created total, federal boards alone, under the healthcare law. The Independent Payment Advisory Board is just one of those 150 that happens to be particularly powerful. Oh, and by the way, to overturn what they say is almost a near impossibility given the way Congress seems to function or not function these days. So whatever they say effectively is to be more powerful than what Congress can do. Increasingly, again, I can give you the nuanced answer. So no, it's really going to be people sitting at the state level and federal level. To be up now, and again, they're smart, but they don't have your interests at heart. So they won't phrase it and say, you know, I'm sorry, you can't have that treatment. What they will do, as they've begun to do already, is create an environment where the services become less available. So that if you don't have access to a certain service or treatment, they won't take any responsibility. They'll say, hey, it's Novack's fault for not offering it, or it's that hospital's fault for not offering it. So that's a little bit of a long-winded answer to your question, but I hope that sort of gets kind of the basics of it. Yes, sir?
Who appoints this panel?
Well, the president gets to it. So the IPAB, it's going to be, they are appointed by the president, and they are confirmed by the Senate. But obviously the president doesn't want to talk about this, which is why he hasn't even put one name up to be.
In regard to that,
Yep.
are they going to be doctors on this board, a percentage of doctors, or just lay people?
Well, I don't think we know. It'll be a combination. And I would make the case, as the luxury of coming from a physician who both is a doctor, well, I'd say not only I am a doctor, Merrick's one, and my dad is one, and my brother-in-law is one. None of us want the supposed smart people sitting thousands of miles away making decisions based upon actuarial tables. We all want data, right? When people come in to see me, rightly so, they say, well, what are the chances that the treatment for this problem is going to be successful, right? I mean, my answer is, well, it's hard to know, right, for sure. We can come with ballpark numbers of success. And patients' families want to have data. But I always come back to this issue of incentives. The incentives for that group are not going to be what's best for you. In the case of the IPAB, their only incentive is how can they wring savings out of the system to make the numbers match up. That is, at the most basic, fundamentally incompatible with you thinking about it, you discussing it with your family, and then your family discussing about it with the people who are taking care of you, to try to figure out so that you can decide, hopefully, what's the best treatment for whatever health condition it is. Yes, sir, I did.
I'm thinking that there's probably about between 65 and 75,000 new doctors licensed in the United States a year, and I'm not sure if that's correct. I do know that approximately 85 to 90% of those new doctors are not general practitioners, they're specialists. And if ObamaCare goes through and we're going to have a whole lot more people going to doctors, there aren't going to be anywhere near enough general practitioners to take care of those people. And the other thing, my concern is, and I know a lot of people who are on multiple drugs. It seems as though the only way certain things are treated are with drugs, and oftentimes they're not the best way to treat something. At least from my point of view, I come from, I'm not a doctor, but I come from 3 generations of doctors. So.
Sure. Let me try to thank you. Let me try to come at that from a couple of directions. I actually do. That's a great question. I actually do not know the exact number of people who come through training each and every year in this country, so I'm not sure. We're having increasingly an influx of physicians from other countries, as you may have discovered if you.
It's about 50%.
If you ever actually have been in the hospital these days, you will find that increasingly you're finding, surely in the ranks of the hospitalists, the internal medicine doctors. They may be wonderful doctors, and I always say this somewhat gingerly because I know a lot, and I have good working relationships and friendly and collegial relationships. But it's a challenge sometimes because I sometimes can't understand them at all on the telephone. And I supposedly know what they're talking about, and it makes me wonder when people who are in the hospital and hurting, who may be slightly hard of hearing and not sophisticated, if they ever have any idea if there's a conversation going on like this with increasing frequency. So I don't know the total numbers. When it comes down to what the healthcare workforce looks like, right? That's sort of what the greater question. Ultimately, the number of moving parts to get us to where we are is much larger than anybody talking head on TV is going to try to spat out in 3 minutes. The environment now where we have more specialists than people in primary care, of course, it all gets back to my favorite word in this, which is the incentives. Right? Over time, the incentives lead more to people moving to choose a specialty over primary care. When the average educational debt just from medical school alone now is greater than $150,000, and people are making decisions and they see a differential, that may be pushing them in one direction or the other. That being said, we also do have there are nurse practitioners, there are more and more people, there are different people doing primary care. But we clearly have an underlying incentive issue, which, by the way, changing and trying to again, by fiat, change it overnight, it will cause all of its own significant unintended consequences as well. The challenge, as you say, is, well, there are 10,000 baby boomers turning 65 every single day, 10,000 for the next 18 months. Healthcare utilization in this country is unbelievably concentrated. The bottom 50% of the entire population, so 160 million people, this is in terms of using healthcare, nobody believes me in this, but it's absolutely true. 160 million people spend a whopping 3% of the healthcare dollars. So 160 million people spend $80 billion. On the other end of the spectrum, 5% of the population, which is about 17 million people-ish, spend 1.4 trillion. That's the differential. And while it is true that we tend to use more healthcare as we get older, even if you look at people who are 65 and older, healthcare utilization is fairly concentrated. And I do get sort of some of these stairs saying, is that really true? It's hard to believe. But if you just think about your family and friends and neighbors and people at church or whoever you do, you realize, well, you know, it's still pretty concentrated in terms of who goes and who doesn't. So we have this challenge that we have a population that is going to be increasingly needing access to healthcare, just by the percentages, but the utilization is very concentrated. We have other rules coming down about all this preventative care stuff that theoretically is supposed to benefit people, although there's some question as to that as well. That for doctors to simply comply with it, I see things about saying, you know, you're going to spend 7 to 8 hours a day just dealing with complying with the routine checkup stuff. So when is there any time left for people who actually have any problems? So I agree, is the short answer. I think we have to recognize that, yes, those things are real. And so when the president and the Democrats pass a law saying they're going to solve, that it's going to be a magic panacea to solve all of our healthcare ills, and we look around and see nothing improving over the first 2 years, and in fact, it's getting more expensive and less accessible, and they can't articulate a single specific policy component that's going to make anything better, we should be concerned. Is that a long-winded answer to your question? Yes, sir.
I think you said that we have a problem with our healthcare in the United States.
We do.
That we need to solve. And a lot of it's money. I mean, you know, just the necessary money to do it. So we have to do that some way. And this organization is pointing out very many difficulties with ObamaCare and with the healthcare system in general. But if you're a lobbying group for what we really need, what is it that you're proposing that you would put forth that, you know, the senior population or the American public really needs? And just with a few specifics that I don't understand.
Sure.
You said that, was the number 750 million out of Medicare?
760 billion, yes.
Billion, okay. On one hand, you were saying that if we took that out, many people would lose, 11 million people would probably eventually lose the Medicare Advantage program. On the other hand, you pointed out that the Obama administration was, at least through the election, propping it up. And you found the GSA said this was very wasteful. So which is it?
Sure.
Is it, I mean, I don't understand what you're saying, because either it's very wasteful, the Advantage program is very wasteful, and we shouldn't have it, so we should save the money, or is it something else you're saying? Because it seems diametrically opposed to what you're saying.
Good point. I apologize if I was unclear. Maybe I was conflating or bringing things too close together. So Medicare Advantage, well, I'll try to, some of that, of course, is probably a little longer talk. I could go on for hours probably, but let me come at it from a couple of directions. Specifically for the Medicare Advantage thing, if it wasn't clear before. Medicare Advantage is flawed. Effectively, how it's functioned since 2003 is a government subsidy program to private insurance companies to provide one-stop shopping for insurance for seniors. In exchange for higher payments, the seniors get one-stop shopping, and they, in most cases, get a broader benefit package than they get under standard Medicare. The downside, you might say, is you are then seeing the patients within the network of the plan that you're in. So it's flawed, but it actually has turned out to be it's been very successful in that there are now 11 million seniors on it, projected to go to 15 million by the end of the decade. So that's 1/5. Right now it's 1/5 of all seniors. And interestingly, it's been the most used by low-income seniors. That extra spending was demagogued horribly by the Democrats in 2009, 2010. They cut that money out They saw it wasn't going, that was not going to work. So they have found other ways to put the money back in. What the General Accounting Office is saying is wasteful about the $8 billion is not that the money is being put into Medicare Advantage. It's that the Obama administration is pretending that they're using this to run a pilot program for quality, when what all they've really done is use that $8 billion to change. Basically, they're grading on a curve and they lowered the curve. It used to be you got bonuses if you were, 4 or 5 star thing. They've changed what they're giving bonus money for, so that the overwhelming majority of plans will now get the bonuses. So it's a lack of transparency and honesty to say that you can't call it a pilot program, because it's not a pilot program. All you're doing is funneling money a different way into it. So I don't know if that clears it up a bit. Into the broader question of, all right, if we think this is stinky, to use a very fancy medical term, what's better? And here's, again, I'll speak for myself, I'm not speaking for anybody else. We have two sets of main issues in this country. One is, we always tend to look at being who's insured and who's uninsured. I think that is a totally flawed method. For the most part, we have an issue of who uses healthcare versus who doesn't. The needs of somebody who's on multiple medications with multiple medical conditions is entirely different from the person who goes kicking and screaming to the doctor once a year. For the person who has multiple medical conditions, as I'm sure anybody here who is in that position or is related to somebody who's been in that position knows, we, to a large extent, have bad coordination. We could put someone on the moon. I could text my wife, over there, and she's in Phoenix. But if I'm one doctor's office and the other doctor's office is where the playground is right there, a medical record can't seem to get from one spot to the next before my visit. So we have a coordination of care problem. We have a certain reproducibility for the folks who use a lot of health care. And we have some management issues for the people with certain chronic conditions. That is where almost all the money in healthcare is spent. It's just the facts of what it is. But it's a very small number of people. That group is entirely different. So again, these numbers come from, these are federal government numbers. So the bottom 50% of the population spends 3% of the healthcare dollars. The bottom 70% spend 11% of the healthcare dollars. So you've got 70% spending 11%, top 5% spend 50%. For those people, and again, playing the percentages, most people in the room, and certainly family members, which is we need greater transparency, we need more information, we need better competition for costs, because it's ridiculously insane and infuriating that someone should be able to show me a thing from their pharmacy saying if I walked in paying cash it's going to cost me $190, but it's only $9 because I had insurance. That is insanely ridiculous. And here's what I say as an orthopedist, which for the occasional healthcare user, which are the bulk of my patients, the truth of the matter is if competition means that it saves $20 or $30 when one of the kids there falls at the park and breaks their wrist because of the way competition is, because a lot of that is reassurance, a cast, and an x-ray. If the single mom saves $20 or $30, that doesn't change $2.7 trillion in healthcare spending, but that $20 or $30 pays for gas, it pays for clothes, it pays for food, and that's what matters. So we need policies that increase transparency to get rid of the third-party payer for the bulk of the population, and we need to honestly look at the people who need health care. So that's the long-winded answer. I hope that helps somewhat. Yes, sir.
Okay, 3 things. First of all, most people don't understand that when a bill is passed by Congress, it is a basic bill, and they add regulations to it later on. So even though this bill was 2,600 pages, there'll be over 10,000 pages of additional regulations added into it. To answer this man's question, Senator Bernie Sanders said that the government will then, if we need more general physicians, the government will pay you to become a general physician, but if you want to become a specialist, you're going to have to pay for it yourself. But my question to you is, what do you know about the bill and the formation of unions, unionizing doctors and nurses and so on down the road?
Sure, yeah, the bill is 2,700 pages long. I know we've crossed the 6,000 page threshold for regulations, and I'd say it's like an iceberg, 95% of the bill hasn't even gone into effect yet. Senator Ted Kennedy famously said that if, he said, I'll let you write the bill, and you let me write the regulations, and I'll beat you every time. And that's why in Washington last year, the year after the bill was signed, according to Open Secrets, again nonpartisan, $500 million was spent on lobbying in healthcare alone. And I will guarantee you that because of the incentives created under the law, I'm sorry the gentleman left, because this is the reality of what's happening is, that $500 million lobbying number, if you add up what insurance companies, predominantly it's insurance companies and hospitals, and to a lesser degree pharma, are spending at the state level on lobbying, exceeds $500 million. Arizona, I can't even tell you, 3 years ago, there were a handful of insurance company lobbyists. Now, there's probably one insurance company lobbyist for every 2 members of our 90-person legislature. It is insane. So, hopefully that's a quick answer to this part. I want to answer a couple more because I apologize, I can't speak too long. Yes, ma'am.
There's a lot that isn't medical in that 2,600 pages. Next year, we are all going to, on the sale of our house, have to pay 1% tax to the federal government.
Well, what it says is that, again, there are well documented, there are about 18 to 20 taxes or so in the law. Since none of us, since the economy is so wonderful, few of us have this, but if you have a capital gains of more than $250,000 if you're a single or a couple, you will have to pay a 3.8% excise tax on those capital gains. So it's not going to be on all real estate. It's only if you're going to see a capital gains of greater than basically $250,000 on your house.
I thought it was 1% over.
No, it's much worse. It's actually 3.8%, but you have to have a certain capital gains to get there. So it actually won't affect most people, but it will change the real estate market.
Yes.
If you've got to make an additional 4%, if you had your home for a long time, if you've owned your home and you paid it off 30, 40 years ago, that 4% impacts the price of the house there. And on unions, real quickly. It is believed, there was an article in Forbes, I think the most recent issue, I don't know if you brought it up, that one of the things that they think some of the unions are trying to do with this whole law is create more and more people who are getting federal dollars in the healthcare sector, being directly regulated by the federal government. And if they do that, they have used that successfully in other sectors to be able to justify allowing them to join federal unions. So, if you forget doctors, but think of all home health care workers, a lot of allied people in the care world. There are millions, remember, 1 out of every 8 people in the country working in the healthcare sector in this country at this point. It's the only sector that's actually shown significant job growth throughout the entire last 10, 12 years. And for every million workers that the unions, federal workers, the union can sign up, that's $1 billion, $8 billion a year in dues. So that's the union issue. I think we have time for a couple more. Yes, sir.
We talked about how Romney's plan may help the situation, but there has to be the repeal process that takes place.
Yeah.
Can you spell out how you think that's going to happen, and can it happen, and how difficult it's going to be?
Sure. So the question is, how can we get rid of this? It's going to be a challenge, because I'll tell you, that $1 trillion to the insurance industry and hospital industry predominantly, they are not going to give that up without a massive fight. During 2009, one insurance company alone had 75 full-time lobbyists working on Capitol Hill. One insurance company alone. Forget all. So the forces against it are going to be pretty enormous. So, so a repeal process, it appears, can be done. And Tom Daschle, former Senate Majority Leader, Democrat, said just at a panel recently, well, this is how it can be done. Is if the Republicans have 50 seats in the Senate, and they have Romney as the president, and they continue to hold the House, because of the budget implications, the largest piece of the $1 trillion going to the health insurance industry, they can run it through reconciliation, which is just a short way of saying they don't need a filibuster-proof majority. That's why the Senate races are so incredibly important, and it's going to be really touch and go on all of that front. So that's the issue. And as to what is it, we don't know the gory details of what a Romney-Ryan plan looks like. And that's the honest answer. It's incredibly vague and opaque and gray. The shell is that if you are over 55, when it comes to the Medicare part, the other part is even more opaque, to be honest with you. If you're over 55, nothing in Medicare changes. That is the plan. And they've said that repeatedly. And so all the ads talking about increased costs for today's seniors was based upon an old version that nobody's talking about. It's just no one's talking about it. If you are younger than 55, when you get to become Medicare age, the way things will be changing in terms of, it'll be more of a defined contribution plan. But you can also have the choice of regular Medicare. Under that scenario, Medicare is sustainable, has a chance to be sustainable. If not, it has zero chance. It is a simple fact. I mean, things that cannot go on forever won't. So, and with what was done with the healthcare law, they talk about an extended Medicare's life, 7 years. Well, that assumes a lot of things that haven't come to pass, not the least of which it assumes about $300 billion in cuts to physician payments over the next 10 years, which no one's talking about. But without those cuts being restored, there's going to be nobody giving care at all, I can assure you that. Because those 10% of primary care doctors, they literally will not be able to afford to keep their doors open. Since we're slated to get a 30.1% cut from Medicare on the 1st of January. So that's sort of the answer. So what to do with the rest of the population, I'm not sure we've exactly seen what Romney's offering. That's where I say internal vigilance from you all is so incredibly important, because there can be a lot of forces, wealthy, influential forces, who seek to benefit from commoditizing you regardless of who is in the White House and who has control of the U.S. Senate. They're going to be working very hard. So 60 plus, they don't get money from, unlike AARP, by the way, who stands to make, they already make hundreds of millions of dollars a year selling insurance. They claim they don't, but they do. If we eliminate Medicare Advantage in large part, guess who gets the benefit? AARP, because now we're going to buy a Medigap policy, and they're the most popular one. And oh, by the way, the federal government was going to limit rate increases. Remember, that was one of the great rules in the law, that if rate increases are going to go up more than 10% a year, you have to get permission from somebody. Well, guess what AARP managed to do? Medigap policies are exempt from the 10% rule. So there's no oversight. Not that the oversight is going to work well in the other group anyway, but they are exempted from any oversight for Medigap policies. So 60 plus, they really do good work. They're not selling you anything. We have the opportunity in today's world to get information from a million different sources. So 60 plus, I would recommend be one of them. Pay attention to what's happening at the state level. Pay attention to what's going on at the federal level. Talk to your friends, neighbors, and family. Nothing is more important than our health and healthcare. And if we aren't willing to stand up and do what it takes to we keep our health and healthcare decision with us and not with the suits, trust me, the suits will be more than excited to take that control. So I want to thank you all for coming out so much. I know that we've got a couple of things here, rapidly items to do, but thank you very much for allowing me to come talk to you. It's always a pleasure to be able to travel all over and be able to talk to groups of all sizes. So thank you so much.